Hello. Thank you all so much for joining us during this the middle of this busy and snowy day for the first of a series of 3 webinars presented by PNQIN, the Betsy Lehman Center, about levels of maternal care in Massachusetts. I'm Sarah Ray Easter. I have the pleasure of joining a wonderful group of colleagues in our state on a task force interested in exploring this issue. And we'll advance to the next slide to just go over a few housekeeping pieces, although we are all unfortunately familiar with Zoom at this point. Is just a reminder, everyone is muted. You can unmute, but we would ask you to keep yourself muted if nothing is to be said. We have a chat button available for general comments or questions, and directly you can reach out to Megan Carey, who is thankfully supporting us from the Betsy Lehman Center for Technical Support. If we're going to have Q&A dedicated at the end, so the chat feature or raising your hand is a great way to get that done. But if we'll advance to the next slide, I just wanted to, on the front end, actually thank all of the folks who have come together, both with their sort of subject matter and technical expertise to make this possible, not only from PNQIN, from the Betsy Lehman Center for Patient Safety, and then our distinguished guests from the Centers for Disease Control. I want to give a specific bit of gratitude to the approaching 40 members of our Levels of Maternal Care Task Force who have been diligently working on this for almost 2 years, actually. So if we advance to the next slide, I would love to just briefly kind of go over our agenda. We're hoping to spend the first bit of time just introducing the idea of levels of maternal care in general, in case this concept is new to some folks. And then we're very lucky to be joined by Jenny Wilkers from the CDC to talk a little bit about the locate tool, which is going to be our way to actually implement levels of maternal care in our state. We then have the pleasure of being joined by Dr. Diop from the Mass DPH and PNQIN champion extraordinaire to talk specifically about parts of the tool that we've modified to better fit our needs within the state of Massachusetts. And then finally, Natalia, data analyst sort of extraordinaire, is joining us from the Betsy Lehman Center for Patient Safety to actually give you a little sneak peek into the locate tool itself, and then hopefully a chance to ask some questions at the end. We'll remind you at the end, but again, this is a first of 3 webinars. This next webinar will be really focused on some of the nitty-gritty of the locate tool once you have an opportunity to play with it, but hopefully this gives a good introduction or reminder for those who are joining us today. So with that in mind, we'll advance to the next slide and just talk briefly about the webinar objectives, which are to go over the process in general and locate specifically with an idea that we hope that everyone walks away sort of empowered to be able to at least start the dialogue with the locate tool for your hospital, or feel more empowered to talk about levels of maternal care and regionalized maternity care in our state. If you'll advance one more slide, I will dive into my little piece, which is for more of a general introduction to actual introduction to levels of care. Again, the levels of maternal care paradigm is something that was actually put forth by the accrediting bodies for many of us, from nursing, midwives, OBs, MFMs, to actually address our nation's growing severe maternal morbidity and mortality issues. If you advance to the next slide, levels of maternal care actually takes sort of what we know to be true, what so much of our obstetric core is built around about neonatal regionalization, and outlines similar levels for the maternal perspective. This is sort of a summary table that Jenny will go into more detail into later, but it lines out sort of the specific level of care, patient characteristics that might be appropriate for that setting, and then specifically hospital characteristics. So for instance, the idea that if you are caring for a patient who has a suspected accreta, you want to be doing that in a place that has the opportunity for OB anesthesia or more advanced imaging to really meet those specific needs of a given patient. engagement in terms of both resources and personnel. If you advance to the next slide, levels of care is actually about more than just sort of putting people into a sorting hat, level 1, 2, 3, 4. It's really about trying to develop complementary but distinct designations for NICU levels of care. Again, the Hallmark paper about regionalized neonatal care came out in the early 80s, before I was born, in fact, and it's so ingrained that it's far overdue that we think about this for maternal levels of care. And the hope is that it's not just about, again, assigning a number or a level to a hospital, but really improving our network to work together and to provide sort of consistent care and equitable care for patients within our state. If you advance to the next slide, of course, everything has a little bit of a downside, dare I say, and I think you can sit around and not think too long and hard if you think about barriers at sort of all of these different levels, going from the patient, i.e. the burden of getting to a different level of care hospital, just from simple things like transport or childcare, all the way to sort of impact on the care region. So for instance, how do hospitals in the Boston area, where you can throw a rock hard enough and maybe hit an obstetric unit, how do these differ from our colleagues serving a role as a critical access hospital in the western part of the state? I think importantly, I just want to emphasize on this slide some of the population health implications of levels of maternal care, because we as a task force have been very focused on that throughout. We are very lucky to live in a state where we take great care of our patients. I see many of the names on the webinar and have been lucky enough to share patients with you. But I think, we really want to be mindful that as we're thinking about levels of care in our state, we're not just improving sort of the care by moving the median actually, but we're actually sort of closing the range, that we're improving outcomes by improving outcomes overall, but also narrowing disparities in care. And I think, if you think about it, the good and the bad of levels of care is that has the potential to perhaps improve outcomes for some, but by doing so actually sort of widen gaps, widen disparities, or promote care that is not equitable. And so later in the webinar, we'll have Dr. Diep kind of focus in a little bit more about how some of these population health considerations have really centered as key in our task force work, and also how those go in with other efforts that we are taking on as PNQIN in general. So if you'll advance to the next slide, I want to just spend one more moment bragging on our task force, a task force that was born actually almost 2.5 years ago out of a goal to be in line with sort of the national climate that's moving towards regionalized maternity care, but trying to make sure we do that in a way that relies as little as possible on legislation or sort of regulation, and really take a collaborative approach. We formed this task force that tried to incorporate diversity of our state, diversity of the different hospitals, diversity in training background, because all of these different subspecialties are represented in the levels of care guidelines, but then also sort of focused on the skill set of locate, sort of a more data analytics standpoint that Jenny's going to tell us more about, but then thinking about other ways we can reach these goals of equity and building relationships between our hospitals. Those of you who have participated in this task force, I can't thank you enough for your time and energy and expertise, and I hope you're as excited as I am today. If you'll advance to the next slide, I just want to highlight even more, not only are we involving people from all the different subspecialties, but we've worked really hard to include people who have connections to other organizations, from Boston MedFlight, CRICO, you see the list ahead of you. People have been real champions, both within the task force and then spreading that out to their organizations. And so if you are new to this space and joining us on the webinar and have interest in sort of being involved, and also feel like you have a network that would be interested in learning more about this, please don't hesitate to let us know, and we'll share contact information towards the end about how you can do that, to try to make sure that levels of maternal care is a paradigm not just for obstetricians or midwives or other OB care providers, but actually becomes a standard of care for women in our state. If you advance to the next slide, I want to just briefly touch base on some of the timeline details. So after a slight delay delay due to, you know, the pandemic and all. We are really excited that our sort of project went live in February of this month. You're here with this first webinar, and then we're really excited that next week, on the heels of President's Day, we'll actually be reaching out to everyone at obstetric hospitals in our state to distribute the Locate survey. We're going to give people a solid month, actually 6 weeks, to get that completed with a few gentle reminders along the way. But importantly, I'd love for you to keep in mind March 2nd, same time, same place, for another webinar where we're going to hopefully open up more interaction to give people a chance to really dive into questions or concerns or you know, things that arise after you've actually seen the Locate tool. The Locate survey will close towards the end of March, and we're hopeful that in April we'll be able to convene with another webinar with some summary statistics, de-identified of course, but certainly to try to provide some direction not only on what we learned from Locate, but how that's going to inform the next steps of our task force. So with that in mind, I just want to advance one more slide and talk about a few sort of special considerations for Massachusetts before I turn it over to Jenny from the CDC. So Massachusetts is a unique and wonderful state, as we all know, and we worked very hard to look at other states and their models of care and their models of implementation to try to inform our own work here in this state. One thing, you're seeing a graphic here from Chris Zahn and colleagues at ACOG, as well as some of Jenny's group at the CDC, where they shared their wisdom learned from implementing the levels of care in 3 sort of pilot states. And one aspect that they really highlighted was the role of this sort of site visit, which has been the model in a lot of other states that are doing this from a more kind of regulatory or place of sort of legislative mandate. And so while that is not our path forward in our state, and we're eager to go forward with this collaborative approach, we heard time and time again how helpful it was to actually have a chance to talk to one another and learn from sort of shared experiences and challenges. And so some of the questions on Locate that will actually be specific to our state explore this idea of whether or not a sort of virtual site visit or consultation for a couple hours might be helpful, both to sort of understand your Locate data a little bit better, but actually provide more sort of personal qualitative feedback about what you perceive some of the benefits and barriers to regionalization to be. We also have embedded in these additional questions, questions that are key to our mission and vision as an organization, which is to eliminate disparities, eliminate racism, and eliminate barriers to equity in our state. We modify these questions from sort of best practices set forth in our disparities bundle. And Dr. Diep will later touch on sort of how we are hoping that the answers to these questions can inform our future work going forward and really align with other existing PNQIN initiatives. The last piece is that we're hoping we're able to really reinforce this message of quality collaborative care. I think Jenny has a few slides talking about this later. You know, the goal of levels of care is not to transfer every patient from their community, from their environment, from their network, from their support system into like the big city hospital. In fact, it's the opposite. It's to make sure that hospitals are outlining what patients they feel comfortable caring for in the moment, what patients they really hope to be able to care for in the future, and to really pinpoint ways that other hospitals, other organizations can help support that work. Again, if you are a receiving hospital from referral, a receiving hospital from one of your partners and referring partners in the community, just as they are trusting you with the care of their patients, the levels of maternal care paradigm would say that you have an obligation to actually reach out and try to help support some of that work in terms of quality and process improvement. And so we hope that with this vision about quality collaborative care in mind, we'll be able to reinforce some of these paradigms that are central to levels of maternal care, but also dovetail really nicely with existing PNQIN initiatives. So if you don't mind advancing to the next slide, I will turn it over to Jenny Wilkers, who we are so grateful to have joining us from the CDC. CDC's been a little busy in 2020 as well, in case no one noticed, but we're so grateful that Jenny and her team are willing to take some time to help us understand Locate a little bit better. So with that, Jenny, I will turn over the Zoom screen to you.
Thank you so much, Sarah, and thank you everyone for your time this afternoon. My name is Jenny Wilkers, and I'm an ORISE Fellow on the Maternal Mortality Prevention Team at the CDC, which is where LOCATE activities are based. And I've been with the team since August, and I'm grateful to have Dave, our team lead, Carla and Alex on the line, who are part of the LOCATE implementation group and have a longer history with LOCATE and risk-appropriate care. Next slide. So I first want to begin by providing a bit of background on risk-appropriate care that hopefully bounces off a little bit of what Sarah was talking about. And risk-appropriate care, also known as perinatal regionalization, was first promoted in the 70s by the March of Dimes Committee on Perinatal Health. Risk-appropriate care is a simple concept to make sure pregnant persons and neonates receive care at facilities that have the staff and equipment necessary to care for them based on their risk factors. The guidelines for these levels of care are set by AAP and ACOG and SMFM and have been embraced by many states. And while the levels of care were embraced widely and quickly, states and jurisdictions have varying criteria for levels, which make comparison across states and jurisdictions difficult. And it's also important, as Sarah mentioned, to note that a higher level of care is not synonymous with higher quality of care. A level 1 facility is fully capable of providing high quality care, and these levels simply define the capabilities of a facility, not the quality of care that they provide. Next slide. So generally the way it should work is that hospitals are assessed and designated as a level 1, 2, 3, or 4, where 1 is the lowest and 4 is the highest. Pregnant persons should deliver at hospitals with the same appropriate level of care available. So for example, if a patient who goes into labor at 31 weeks should be delivering at a hospital that is prepared to take care of a very preterm infant, as opposed to a hospital or birthing center that's only prepared to care for term healthy infants. And at the system level, the level 3 and 4 hospitals should work to provide support to level 1 and 2 hospitals when needed. Next slide. So these are the definitions for neonatal levels of care according to AAP, which were last updated in 2012. As you can see, the levels are defined in a stepwise manner, with each level including requirements for those below it in addition to its own additional requirements. And Massachusetts may opt in or opt out of the neonatal portion of the survey. And so the majority of this presentation will be around the maternal portion of the survey. Next slide. So these are the definitions for the maternal levels of care according to ACOG and SMFM, which were last updated in August of 2019 and mimic the neonatal levels of care. Next slide. So a challenge that's shared between levels of neonatal care and maternal care is the low number of states that have implemented state guidelines and variations in criteria from both AAP and ACOG and SMFM guidelines, but also variations between each other. Next slide. And so these challenges are a larger part of why LOCATE was created. And LOCATE, which stands for the Levels of Care Assessment Tool, is completed by each hospital in the state that cares for birthing people and or neonates. It contains questions that address guidelines by AAP and ACOG and SMFM, and the information is used to produce standardized assessments to provide information about the levels of care the hospital provides. The primary purpose of LOCATE is to facilitate and increase stakeholder understanding of the landscape of perinatal care available and foster stakeholder discussions and conversations that can strengthen systems of risk-appropriate care. Next slide. It is also important to be clear about what LOCATE is not. LOCATE is not a comprehensive assessment of all neonatal and all maternal criteria. It is not a tool for formal designation of levels of care, and it is not a tool for healthcare regulation. Next slide. Here's a quick overview of the development of LOCATE. In 2013, after the release of AAP levels of neonatal care guidance, LOCATE was formulated and pilot tested in 5 states. In 2014, testing continued to roll out in 2 states, and full capacity for LOCATE rollout was established. Fast forwarding to 2018 and 2019, and levels of maternal care had been added based on ACOG and SMFF guidance. Version 8 of Locate was being implemented, and by the end of 2019, 17 jurisdictions had participated in Locate. And as of 2019-2020, in compliance with the 2019 levels of maternal care updates, Locate has been updating to version 9, and 3 jurisdictions have already implemented, with 9 more pending assessment dissemination. Next slide. This is just a visual for you all to see where Locate has been implemented. And as of now, 21 states, Puerto Rico, 1 perinatal region in Michigan, which is where the triangle is on the map, and 1 large health system have implemented Locate. And Massachusetts is our only state currently in process. And implementation is defined by having at least begun data collection. Next slide. So Locate is completed using one of 2 web-based platforms, SurveyMonkey or REDCap, and the assessment includes questions about services and personnel, subspecialists and their availability, self-reported levels of care, volume of services, drills and protocols for maternal emergency transports, and facility level statistics. Next slide. The Locate process typically begins by jurisdictions building support for participation. This includes their identifying champions, engaging stakeholders, and fostering relationships with facilities. When the state is ready to implement Locate and collect data, the lead organization, which for Massachusetts is the Betsy Lehman Center, provides facilities with the link to the Locate assessment and then follows up with non-responders. The lead organization then sends the data to CDC, and CDC assesses the levels. We then provide the results back to the lead organization, who can use the data and share as best meets their needs. Next slide. And while the most obvious piece of information we get from Locate is information about discrepancy, there are many ways the results from Locate can be used. And towards the end of this presentation, I'll share some of the ways that a few states have decided to use their results from Locate. Next slide. Oh, great. So I'd like to briefly share the accomplishment of 2 states who implemented Locate, with the first being Illinois. The Illinois Department of Public Health was interested in using Locate to compare their state's perinatal system to AAP and ACOG levels of care, and eventually inform policy decisions to improve care for mothers and infants. And following implementation, a state epidemiologist performed multiple analyses to describe their levels of care and the potential impact of changing levels of care to current national guidelines, as well as neonatal mortality across and within levels of care. And the findings from these analyses were used in the adoption of the current AAP guidelines for neonatal levels of care. Next slide. Another success is Wyoming. Wyoming implemented Locate to capture facility responses, as well as bordering states who receive high-risk pregnant and postpartum patients from the state. And after completion of Locate, Wyoming conducted an analysis of severe maternal morbidity by combining severe maternal morbidity data with Locate levels data. And the results from Locate identified several facilities that did not have specified maternal care protocols in place. And this resulted in Wyoming facilities participating in the Utah Department of Health Extension for Community Healthcare Outcomes, or ECHO, for hypertension and pregnancy. Next slide. So we've provided some information to folks from VLC on tips from states on implementation of Locate. And our main tip just for today for folks completing Locate is to have someone double check responses before submitting. It will ultimately save you time, since this will allow us to process and provide results back to you with minimal back and forth. So the more people that can take a look, the easier it'll be going forward and the less work you'll have to do moving forward. Next slide. So I just want to say thank you so much for your time. If you have any additional questions or concerns that may not be addressed at the end of all the presentations, please feel free to reach out to someone from Betsy Lehman Center, who can send an email to me or anyone on our CDC team. And we greatly appreciate your time And I will now pass the mic to Dr. Diop.
Thank you so much, Jennifer. If you can go to the next slide, please. Sorry, I forgot to say that I am have such a job known as Fifi to many of you. I direct the Division of Maternal and Child Health Research and Analysis at the Mass DPH, and also serve as the PI for PNQIN. Next slide, please. So, as Sarah mentioned earlier, the Locate survey includes specific questions related to equity, and we are very intentional about including those in Massachusetts. As I'm sure you all know, Massachusetts is consistently among the 10 healthiest states in the country, but underneath that accomplishment, we know that racial ethnic health inequities exist and have persisted for decades despite our effort to improve outcomes. At the Massachusetts Department of Public Health, we are committed to providing timely access to data to eliminate institutional and structural racism, which contribute to the inequities in health outcomes. This slide has been widely used to illustrate the difference between equality and equity, where equality means everyone benefits from the same equal support, whereas equity means that everyone gets the support they need, and liberation means no more barriers and everyone can enjoy the game. Now, why is equity important for the maternal levels of care? Well, it allows for better utilization of services. For example, ICU beds should not be wasted to low-risk patients and vice versa, as both Sarah and Jenny mentioned earlier. The same is true when considering geographic location of different hospitals, urban versus rural, and challenges associated with transportation among the most vulnerable populations. As shown here on this slide, to achieve equity, there is no need for additional resources. What happened between equality and equity was just a redistribution of existing resources. So keep that in mind as you think about our state and as we implement the maternal levels of care. Like Jenny eloquently said, higher levels does not mean higher quality of care. Patients should be cared for at the most appropriate level so that resources are not wasted. Next slide, please. As we've been doing this work related to addressing inequities in our state, what we heard was the lack of knowledge and training among our providers. And for the last year or so, we've partnered, PNQIN particularly partnered with Dr. Annie Lewis O'Connor at the Brigham and Women's Health Care Clinic to offer a series of 2-hour virtual training on stigma, bias, and trauma-informed care across 15 hospitals and trained 185 providers. And we also created a 1-year program with C credits, which is posted on our PNQIN website for anyone who is interested in learning more about stigma, bias, and TIC, trauma-informed care. Next slide. We are also currently offering implicit and explicit bias trainings through the Institute for Perinatal Quality Improvement Speak Up for Black Women, which allows providers to learn about strategies to support individual groups in dismantling racism, providing quality, equitable care, and reducing disparities. We have 3 trainings lined up between March and May. There is one in March, May, and September 2021. We have funding from the Mass DPH to support these trainings through September 2022, next year. Next slide. The Department of Public Health has also created a tool known as the Racial Equity Data Roadmap in response to the need of different community partners, including different hospital institutions related to better addressing inequities. What we hear a lot is that we understand there are inequities, but we don't know how to tackle them. We don't know what to do. And we are offering tools and resources through the Department of Public Health to support institutions and individual providers who are interested in doing more work related to equity, recognizing that different people are at different levels of readiness when it comes to their equity journey. Next slide. Here is a beautiful slide stolen from, I believe, Dr. Dave Goodman from the CDC, which is a good illustration of how you can utilize existing resources and how you can build on collaborations to improve outcomes, maternal health outcomes, starting with the Maternal Mortality Review Committees known as MMRCs, where these committees conduct comprehensive reviews of maternal death. And Massachusetts does have a very robust MMRC committee, and how we make recommendations through the MMRCs to the state PQCs, being the arm, the implementation arm, using tools provided by AIM, the Alliance for Innovation Maternal Health, through the bundle implementation. So you can see how the maternal levels of care nicely fits into these three components, where patients receive their care in the most appropriate settings. Next slide. Here, this slide shows our current SMM, severe maternal morbidity rates by race ethnicity during 2009 and 2018. What I wanted to highlight here is the huge gap we see between Black, non-Hispanic, and all other races. As you can see, the lines for all other races are pretty much around the same place, clustered together, when the line for Black, non-Hispanic is super high compared to the rest. What is also important to note here is that the rate for Black, non-Hispanic in 2018 remains still higher than the rate of any of these other groups in 2009, which is extremely important to think about in terms of how much progress and advances we've made in the medical field for this group to still be more than a decade behind all the other groups, is what we're talking about. We are in Massachusetts trying to lift off, lead with racial inequities, recognizing that there are many other forms of inequities, including geographic inequities and inequities due to disability status. But we are again trying to improve inequities for Black women. And as you may have heard, our governor signed a commission, a legislative commission to address inequities in SMM for Black women in Massachusetts in January 13. If you go to the next slide, this slide is similar to the prior slide. The difference is this one includes SMM and transfusion. I apologize if we haven't defined SMM for you, but it's really unexpected outcomes of labor and delivery complications, including hemorrhage, amniotic fluid embolism, acute renal failure, etc. And the difference between SMM 20 and 21 is that SMM 21 includes transfusion. However, looking at the data, just to highlight the data, the differences by race ethnicity persist, and they are seen in every single outcome we have in the state. And I believe that's my last slide. Next slide. And now it is my pleasure to turn it over to Natalia.
Wonderful. Thank you so much, Fifi. And thank you everyone for joining us on this first webinar for the Locate tool. My name is Natalia. I am the data analyst and coordinator at the Betsy Lehman Center. I've been working with PNQIN for about 2 years now, helping with the AIM initiative and with the Locate project as well. So I will stop sharing my screen. We have plenty of time to go through the survey tool, which is really exciting. So let me take a moment here to switch my screen share. So Within the next week, you will be receiving an email from Sarah Ray or Kaylee from that end with the introductory letter for your hospital and the survey link. Upon opening the survey link, you'll be brought to this page. This is the locate tool. Finally, here we are. The welcome page will provide you with a PDF instruction. You'll be able to open this. I highly recommend you go through that instruction page if you want to see exactly what each question is asking you for, and to have your information prepared in advance, just so it's easier for you to fill out the survey as you go along. I would like to also emphasize that there are several sections to this survey. If you find it's taking a long time, you do not have to complete it all in one sitting. We have a save and return later feature. When you click this, it will save your progress, provide you a code, and then you'll be able to use the same exact link to access that we provided you for the survey to access it again. And I can help you troubleshoot with that as well in the back end. So moving forward, we'll be asking, this is just an example that I filled out just so it's easier for us to click through. We'll be asking demographic questions about your facility, its location, zip code, the kind of reimbursements you receive, and what federally funded programs those are coming from, the date of the survey completion, your information and your email, so that in case anything happens, again, on the back end, I am able to identify who you are and reach out to you about the data and your survey response. As well as, just like Jenny said, make sure you have people help you look again and confirm your submission. So anyone who helped you fill out the survey, please list their titles so we know who was involved in this process. Moving forward, so we will ask that you specify the time period of the data you will be reporting on, and hopefully that's about a year's worth, or that 12-month time frame. The first section will be the neonatal care section. So for the state of Massachusetts, we probably would have access to your neonatal care level. If it's a huge burden, you do have the option to skip this section. However, we highly recommend and would prefer for you to take the time to fill this out, just so we have complete information for everything. So this is a combination of questions that ask, asking about the types of surgeries and the types of how often those surgical events have occurred, whether it's congenital cardiac surgery or complex pediatric subspecialty surgery. It goes on to ask about the specific neonatal providers you have. You check off all that are relevant and available for your facility. And for each one, we ask how often are they available, or the degree to their availability. So of course, as you probably already have noticed, the more resources your hospital has and the more you are able to support complicated events and patients, your survey will probably be a little bit longer. So, don't be frustrated, stay with it, and just take the time you need to fill it out. But that's just our disclaimer, and we appreciate you for having those resources and providers for babies and mothers. Again, asking for specific subspecialties and surgical specialists, you check off all that apply. We ask again about their availability. Moving on, the types of imaging and interpretation services you have available in the last 12 months or year. How often were these events occurring, or did 10 or more events occur? Complex ventilation, same thing, did more than 10 events requiring these resources occur? Do you receive neonatal transports? For what kind of neonates? High risk, convalescent? Do you have a coordinated emergency transport for neonate? Yes or no? And then finally, at the end of this section, it will ask, do you have a neonatal level of care designation? You say yes, you can say yes or no, you provide your designation, and then you specify where that designation came from. The final question asks you to take a look at the guidelines provided in this link and to actually think about the resources and the questions you just answered and see if you do match that level in fact, and kind of rate yourself once again. So that is the first neonatal care section. After this, we ask for neonatal statistics. So again, we hope that this isn't a huge burden on your facility, and we don't intend for this to be stressful. We hope you can provide as accurate data as you can, but again, don't get too caught up or stuck in this section. So it will ask for the number of live births, the number of deaths at your facility, the number of low birth weight infants, and those that have a gestation of less than 32 weeks. And then it asks a combination of questions with how many of those, low birth weight had died, how many were transferred out, how many of a low gestational age were transferred out or were received in, and how many of those had died. So just looking back on your records and trying to identify those events. Finally, we come upon the section we are most interested in, the maternal care section. So we want to emphasize, please, please, please fill this out. Take the time to fill this out. Again, it gives you the option to skip. Please don't skip it unless it's irrelevant to your hospital. But that question 1 actually will decide that for you. So it asks, do you have an obstetric unit? And this tries to filter out small rural hospitals or other children's hospitals. And that will take you straight to the maternal statistics page. Once you move past that question, it will ask you the type of maternal and obstetric care you're able to provide. Is it low risk, moderate risk, high risk? You check all that apply. This section is a combination of questions asking about, policies, measures in place, the types of resources and staff and providers and subspecialties you have available. So it does, again, it can become longer as you have more resources and providers, but again, we ask that you take your time, you can save and continue later. So this asks, do you have a formal written plan for transfer of complicated obstetric maternal patients? Yes or no? What does this formal plan include? Do you have ICU units? Are they medical? Are they surgical? Both or neither? What kind of critical care providers are available? Are they available? The types of, is there a fetal medical specialist available as well? And who are these, who is this intensive care unit managed by? Do you have basic medical support services, laboratory or blood bank, or both? And then are you able to initiate massive transfusion protocols with the blood bank? Next, we ask, if you do say yes to both of these, then it asks for the types of diagnostic imaging services that you provide at your facility. You check all that are relevant. And again, we ask how readily available these services are for each that you check off. Another question that comes up is subspecialty surgical services. And again, you check off the ones that are relevant to you. Do you have written policies and procedures in place for morbidity events? And do these include specifically for hemorrhage events, for hypertensive events? And if so, do you have practice drills in place again to for these specific hemorrhage and hypertensive events? Yes or no? Is there a birth attendant and is there a qualified birthing professional? Yes or no? And what are the types of obstetric providers that are available? You check all that apply. And again, for each of these, we ask about their availability. And for some, but not all, there's a question that may ask about board certification or board eligible provider. Question specifying C-section and what type of physician is present to support that. Questions regarding specifically anesthesia and the kind of certified nurse or provider that can support that as well, and how readily available they are to provide those services. What else? General surgeon, again, availability. And then we come to a higher level question asking about types of board certified or board eligible physicians. And again, you check all that apply, and we ask for the availability for each of these providers. Finally, once we get to the end, there's a question asking, does your facility currently have a maternal level of care designation? For the state of Massachusetts, the answer is most likely no. So we ask that you check off no. And then again, just like in that neonatal section, it asks you to look at the ACOG link and look at those guidelines and kind of rate yourself. What, based on the questions you answered and your resources and providers, do you consider to be your level of maternal care? And then finally, To complete this maternal section, there's 2 more shorter statistics pages. We ask for the maternal statistics, women who delivered, how many were transported out, how many received 4 or more units of whole blood, how many were admitted to an ICU, and any deaths. Final fetal death statistics page asks for the number of fetal deaths per different gestation categories. And then come the 2 easier portions. So there's one asking just 2 simple questions, asking about hospital preparedness, response, and recovery. So do you have disaster response drills in place? If yes, for which of your units, neonatal or obstetric or both? And then finally, just as Fifi was presenting on this section of the survey is specific to Massachusetts, where we target questions about inequity and racial and ethnic disparities. And this is again to eliminate racial and ethnic inequities. So we'll ask, the first question asks, do you have any anti-racism or implicit bias training within the last 2 years, and for which of your staff or providers? Do you have a system in place for patients or families to report discrimination, racism or bias? If yes, describe. Similarly, do you have that system in place for staff to report on these? If yes, please describe. Do you have a regular program or educational process in place to address these disparities or any racism or ethnic inequity? Again, you specify for which staff. And then finally, a couple of questions asking when you do have debriefings after a clinical event, do you systematically address patient race, ethnicity, language, poverty, all these types of social determinants of health? And then you specify how often this happens, and similarly, specific to severe maternal morbidity, does your hospital also systematically address these? Finally, we asked 2 questions that ask, does your hospital perform a root cause analysis or a similar review process? Yes or no? And then as Sarah Ray touched upon at the beginning, we ask if you are interested in a voluntary consultation for Locate as a way to kind of get a gist of how we can support you. And if you need that help, there's never a reason to say no. We are always there to provide that extra support. So finally, hopefully, once you've completed this, reviewed it, ask someone else to review it, ask a 3rd person to review it if you can, you click submit and we'll see the response back end. And if you have any issues whatsoever, I will be checking the back end of the survey periodically, following up with you regardless of if you completed the submission or have a partial response, just to check in and make sure everything is as it should be. So just to be aware that we have some time for questions for Q&A, I'm going to stop sharing my screen and then reshare the PowerPoint presentation. Ooh, seamless transition, beautiful. Let me go on to the next steps, and back to you, Sarah Ray.
Absolutely. Thank you so much, Natalia, both for that sort of artful demonstration of what's, can be intimidating, but you do a great job making it approachable. And then also just for all of the work that you've done to try to help get this tool in the hands of our state. So in the remaining time that we have left, I'd love to invite people to share, any questions or concerns, and then be on the lookout actually for a formal sort of introductory letter and a survey link. We will be sending that to sort of contacts that we have either through existing PNQIN initiatives or, our friends who have, suggested, oh, this person might be interested, that person might be interested, sort of at the leadership level of our Massachusetts birth hospitals. But we recognize that there's a lot asked of many different people, and especially more in sort of 2020 and 2021. And we're really hoping to get 100% participation in this initiative from our Massachusetts maternity hospitals, recognizing that hospitals that our smaller hospitals, critical access hospitals, may have less resources to sort of delegate this to a willing, a willing colleague. We really do want to do anything we can to help support this work so that everyone's voice is heard and so that we can understand the landscape of our state to improve outcomes for our patients and frankly to make care patterns easier for ourselves. So the letter will be going to identified leaders or friends of PNQIN, but hopefully at a multidisciplinary level, both including sort of obstetric care providers as well as our essential nursing colleagues. That being said, if there are folks who you think that within your institution this is their wheelhouse and you want to include them, by all means, please do. The more eyes and the more reliable the data and the more voices, the more we can make this an initiative to support everyone else. And we will be sending out, here in a couple of weeks, invitation for our second webinar, which, we really hope will take a deeper dive into some of the challenges that people are sort of facing kind of globally, or just very specific questions related to locate. As a part of that, we hope that you would engage others who might be interested in this sort of domain, and also bring your questions, bring the hard ones, because it's something we've spent a lot of time with a lot of people a whole lot smarter than me, thinking about sort of all the different consequences, I guess, so to speak, both good and bad, unintended and otherwise, of this type of initiative. And we want to make sure that we're being as comprehensive as possible. And then again, once we sort of have a better sense of when the data comes back, how clean the data is, we'll be in touch about that third webinar. So with that in mind, I'll advance to the next slide, which puts an email to hopefully be a central sort of point of contact for any questions that people have in follow-up. That being said, I would love to try to address any questions in the remaining time that we have left. I see a great question actually from Mildred Mendez in the chat about what type of questions have you received about the use of the survey and how are you including hospitals and stakeholders in the assessment of maternal levels of care once the surveys have been analyzed and discussed? That is an excellent question and summarizing, I think, some of the challenges that we've spent a lot of time thinking about. So I'm actually going to answer the second part because I think it informs the first part. So the locate tool is meant to do exactly what's embedded in the acronym. It's meant to be an assessment. It's meant to be a tool to help hospitals. It's not meant to be sort of the magic sorting hat that tells you level 1, 2, 3, 4. And that is absolutely sort of the truth about your kind of level of care and dictate your care paradigm going forward. The goal of the tool is to help see actually if what national guidelines say about your level of care align with your own perception of your level of care, and actually where things are discordant to identify opportunities to help sort of you meet your goals. And that actually goes both ways. In data from the state of Illinois, actually, when they compared the locate assessment of level of care, and Jenny, please correct me if I'm wrong here, to the self-assessment of level of care, about 50% of the time, locate said the same thing as hospital stakeholders. I think when they were discordant, interestingly, about half the time, locate assessed a hospital at a level lower than the hospital self-assessed. And then the other half the time, it actually went the other way around. Locate said, hey, you're a level 3 hospital, whereas the hospital said I'm a level 2. And so I think part of the goal is to actually be introspective and sort of give people a suggested level. And so if you're in that category where you're aligned, great. If you're in that category where locate says you're a level 2, but you think / hope you're a level 3, being able to break down and say, like, listen, we just need access to an MRI. That's really what is a barrier to sort of being a level 3 hospital or what have you, and hope that can be a tool to sort of lobby and say among sort of hospital leadership, like this is sort of what other hospitals similar to us, what they have available to them, et cetera. I think, similarly for hospitals who say I am a level X hospital and and Locate says that you're a level X+1 hospital, recognizing that perhaps there are patients that are being referred out that would actually be appropriate within your wheelhouse, and trying to help sort of people perform at the level that they would like to be, if that makes sense. So it's just a suggested level. We made a very deliberate choice very early on in this process to not make this regulatory, to not have this associated with some sort of PNQIN, like stamp of approval, you are level X. This is about helping hospitals be the best versions of themselves so we can take the best care of our patients. Regarding sort of the questions about the use of the survey and including hospitals and stakeholders in the assessment, I think aside from actually giving hospitals the opportunity to do what they will with their suggested level, both sort of internally, but in sort of within their own operations, but then also in thinking about their relationships with other hospitals, we're also really hoping that hospitals and stakeholders will be willing to engage at this sort of site consultation or whatever you call it. I'm not sure what the right answer is. All I know is that from the very beginning, the site visit group put the universal theme is that we want to be the exact opposite of JCAHO. So if this is JCAHO, we want to be the opposite. We want to come in with smiles on our faces. We don't want people to hide their drinks or do whatever you do when JCAHO comes. With that off the record comment, and just be honest and forthright about what are the challenges in the space. What do you experience as a care provider serving your unique community, and how can the hospitals in your network, how can PNQIN as a whole support that? And I think that's the type of face-to-face interaction that almost every state that's implemented this, almost every leadership group that's taken a role in this is really emphasized as being important. The questions that we have received about the use of the survey and about how this is going to be used have been so incredibly thoughtful, and I think really highlighted opportunities to be responsible with this initiative and improve patterns of care. When in-person grand rounds used to be a thing, I got to learn a lot about the geography of Massachusetts through kind invitations from many of the people on this call to talk about this initiative. And in general, I spent 30 minutes chatting and then 30 minutes listening, because certainly the work that this task force has done has been informed by stakeholders from the very beginning, not only in the people who are involved in the task force, but also in that follow-up. So I think that, those are some of the goals that we're hoping to meet with engaging hospitals and stakeholders. And again, if you have a suggestion of a better way to do that, if you want to, throw yourself onto yet another Zoom call to share that voice, it is absolutely more than welcome. I have a great question from Ellen Bird in the chat about behavioral health and MAT resources and the level of care. I want to be I might actually, Jenny, if you don't mind, kick that to you because you have the global vision. But I also just wanted to highlight one point that Dr. Iverson, I think, has drawn before us as a good analogy in this idea of sort of stakeholder engagement. One thing that I think has been an impressive model, when you think about perinatal quality collaboratives, California obviously pops into mind, and they have really used this type of initiative about regionalized maternity care, not just to understand sort of maternal morbidity prevention in sort of the day-to-day, but actually to think about things like disaster preparedness or sort of overflow, so that when they are, slammed with COVID patients or when the next pandemic occurs, they have really clear patterns and really obvious networks. So I think if, this past year has taught us anything, it's about the value of collaborative multidisciplinary care and being a team player. And so I hope that this initiative via stakeholder engagement and other pieces goes into that. So with that, I'll be quiet and listen to Jenny's expertise.
Oh no, Sarah, you're doing such an amazing job. Thank you so much. I wanted to piggyback off of one quick thing that you were saying, and we have aggregate data so we ask a question in the survey, what is your self-assessed level of maternal or neonatal care? And we have data from 767 facilities in 15 jurisdictions. And what we found when looking at the self-assessed level of care for the maternal portion of the survey versus locate assessment, that the majority of facilities locate assessed as a level 1 or 2, and there were more self-assessed level 3s and 4s than locate assessed. So the majority of facilities were giving themselves a higher level than what was actually assessed after we had reviewed and assessed the data and sent it back. So just wanted to throw that out there, that we did have some numbers on that. And then regarding the behavioral health question, behavioral health staffing is asked about, but nothing specific to Matt.
I want to be mindful of time and just grateful for the time that you've already dedicated to this. As someone who is, really terrible at ending clinic on time, I'll at least try to end this webinar on time so that you can start your clinic on time and maybe do better than me towards the end of the day today. Again, the best ideas I've had and the most sort of inspiring and motivational moments of 2020 have really come from working with this wonderful task force. So I welcome anyone to reach out with questions, concerns, bandwidth for more Zoom meetings or participation as you see fit, and want to again express my gratitude to my co-presenters, Dr. Diep, Natalia, Jenny, Kaylee, and Michelle, the amazing people behind the scenes, making sure we don't do silly things like break the internet, and then recognizing that those are the smiling faces behind the amazing, or representing the amazing teams that are well supported both at PNQIN, the Betsy Lehman Center, as well as the CDC Locate team, who I think amidst a pandemic have maintained the most positive attitude ever. So thank you all so much for this opportunity, for your attention, for your participation, and for your ongoing collaboration. Have a great rest of your day.